My name's Tom Buchholz. I'm a radiation oncologist at Scripps MD Anderson, where I'm also the medical director of the Scripps MD Anderson Cancer Program. Radiation plays a very important role in breast conservation management. It's been studied now in numerous trials. And when you conduct a meta-analysis of all these results, radiation's very conclusively shown to decrease the risk of any breast recurrence and also improve survival. And yet we know that perhaps not every single patient needs radiation after breast conservation. There are some very favorable risk groups where the risk of recurrence with surgery combined with hormonal therapy, because one of the factors for favorable outcomes without radiation is the presence of ER and PR positive, HER2 negative disease. So in that setting, we could sometimes consider omission of radiation. The most important factor, again, would be having the presence of stage 1 ER, PR positive, HER2 negative disease. And then the other factor that we consider to be very important is the patient age. So clearly radiation should not be given to someone treated with a very short life expectancy. So if we saw someone with significant comorbidities where you thought their life expectancy was under a year or so, then radiation is really not necessary. There have been trials that use just chronological age as a surrogate for life expectancy. And the first of these trials investigated omission of radiation for patients over the age of 70 with stage 1 breast cancer that was ER/PR positive, that was going to go on to receive hormonal therapy as a component of their treatment as well. And in that setting, radiation showed a small statistical benefit in prevention of recurrences, but really the absolute magnitude of the improvement was really low because both radiation did well and the omission of radiation did acceptably well too, with recurrences well under 10%. In part, that's because the rates of intercurrent disease death is higher as you age. So clearly, if you're 90 years old, you might not enjoy a 10-year benefit from radiation. So it's important not just to consider chronological age, but what you estimate for the patient in front of you. If you're 70 to 75, you have a longer life expectancy than if you're 85. So age is important, but also the predicted life expectancy of the patients. So if someone's in their early 70s, I certainly have a discussion with them about radiation use. If they're training for their next marathon, I'll probably consider using radiation. If they have, significant cardiopulmonary disease and diabetes, I'll probably encourage them not to receive radiation because I don't think it would have a big impact on this. There are newer ways to further evaluate selection criteria for omission of radiation. And not surprising, there's ongoing investigations now looking at more sophisticated molecular markers. Even in the setting of ER/PR positive disease, we know that the oncotype, for instance, does predict not just for distant recurrence, but it also predicts for local regional recurrence. So there's ongoing studies in the United States looking at oncotype or the PAM50 markers to determine whether those low risk categories can potentially be treated just with surgery and endocrine treatment alone and omit radiation. Now, that all being said, radiation isn't the worst thing in the world to receive. With hypofractionated radiation, some of these low risk situations can potentially be treated just with a week of treatment, and the treatment itself is really well tolerated. So it's kind of a trade-off between not receiving any treatment at all or receiving a treatment that's very safe and effective. And again, those decisions I think have to be considered on an individual basis. But clearly the things to consider is estrogen receptor positive disease, HER2 negative disease, the age of the patient, the grade of the disease, the surgical margin status, and whether they're going to be using endocrine treatments moving forward.